when respected teachers, I started here all my studies in medical school in '89, and my teachers are here. Respected teachers and friends, honored to be back in Trivandrum. When Vishali Madam finishes, the pain is felt by the next speaker, unfortunately. So you are going to be disappointed with my talk. That is for sure. So Arshali told me unconventional decisions in vitreoretinal diseases. Unfortunately, these unconventional decisions cannot be spoke about in public. Many of us do that. So I thought I will select something that I do regularly, unconventional, that too in medical retina. Okay. So why unconventional? Because what is unconventional? It is treatments that differ from generally accepted standard of care. This may be due to poor outcome of standard of care, like CSCR. Many times our treatment will not work in recurrent CSCR. It may be due to economic burden on the patients, like repeated injection. You keep on injecting. That could be one reason. You have to decide on whether to do anything, do a conservative management or do unconventional treatment like what I am showing. But whatever you do, you get document it and get an informed consent that this is not the standard of care. So I am talking about micropulse laser, which I have been using for the past 8-9 years. This may work. I am showing only, like all our presentations by surgeons. No, we speak about only the best case that we have. That is, so all the listeners will think that that is going to happen in every case, which this is not going to happen. So I am going to talk about micropulse laser and some good results that I obtained with micropulse laser. So why we give laser in many of these diseases? You have to give the laser focus to the retinal pigment epithelium, and it should, that heat should be the effect of the laser should be only confined to that area and should not cause collateral damage. Unfortunately, all our lasers are long duration, so that it will spread the heat to the surroundings, enlarging the scar. So ultra short microseconds micropulse laser causes increase in temperature right only for that time, and it minimizes scarring. It has some similarities with the old transpupillary thermotherapy that we used many years back, which we used to call slow cooking for a long time. It is a small train of pulses of laser, and which actually the duration is very small, and it causes VEGF down regulation by stimulating the RP, and the collateral damage is very less. Heat is not allowed to spread beyond that area. Okay, so that is primarily it is focused at the retinal pigment epithelium where there is melanin, and it also increases the expression of heat shock proteins, which may restore cellular function in RP. So this is a theory. Forget about it. It's basically a short duration laser with less collateral damage. Unfortunately, you can't see the effect of the laser immediately. That is like in TTT also, we never used to see the effect of the laser. So probably these are all indications: central serous retinopathy, PCU, AMD, RVO, DME, wherever your treatment is failing, you can try this. So let us see some cases. So this is again multimodal imaging. You don't need to diagnose that this is CSR, but you can see that fundus autofluorescence is showing gross changes in the macula, which tells you that it's a chronic degenerative type of CSR. And this is the OCT, angiogram, where you can see one major leak and multiple small leaks are also there inferiorly. So this is the picture. So unfortunately, it is little difficult to treat all the leaks around the fovea. Multiple small leaks are there. One is big one. So what I did was micropulse laser with a grid of micropulse laser. After titrating, actually you can use the micropulse laser to produce a burn as a test burn and reduce the power to half and then only give this. That is a way to titrate the micropulse laser. So this post treatment, it is dry in all the sections within 3 months, and he has been continuing to be dry after 1 year also. Case 2, another one, multiple small leaks with the peripapillary changes, and it is little difficult to treat with focal laser in all these areas. So this is the picture, pre and post micropulse laser. This is the initial one. Right side is the after 3 months. You can see that fovea is getting dried, and gradually that macula became flat over the next few months. Case 3, again, this is what? Fibrin CSCR. So fibrin CSCR with that central hypo area you can see, and this is the imaging. That vacuole sign is seen at that area of fibrin, where there is the fibrin is pushed to the side by the powerful jet of the leaking fluid, and it is very difficult to treat these cases with thermal laser, which can cause severe scarring. So this I did with this is angiogram. Large leaks are there in 2-3 places. So I did micropulse laser as a grid on the whole area as a grid, and after 3 months you can see that fluid has already gone with a best corrected visual acuity improving to 6/15. But still the fovea, that RP has not been restored. So over time, vision gradually improved with the regeneration of retinal pigment epithelium at the fovea. So this is before and after treatment of CSCR. Case number 4 is another recurrent CSCR. This is really degenerative CSCR with lot of pigment alterations, RP, atrophy, staining, etc., etc. So this is the sick RP. So these are the fluorescein angiograms. So where to treat? You can't even see a proper leak, but there is fluid in that central area. So this case, there is no other choice, because I used to do photodynamic therapy. It was not available. We have started getting the dye again. So we have started back. But at the time of this case, there was no PDT. So I did micropulse in this area. And after 3 months, the macula is dry in the right eye. And but he is going to recur with the sick RP over the next few months. Case 5, this is little different topic. Gradual defective vision in the right eye, 3 months, metamorphopsia. We are all worried about these sort of large pigment epithelial detachments because it may rip. That is the worry. So left eye is okay, right eye has a huge extra large PED with a typical notched PED, and at the notch there are polyps, bunch of polyps, and it is little tricky. Without treatment also it can rip, but with treatment also it can rip. So what I gave one injection, Visitain was not available. I have treated few cases with PDT in that area only, but it has worked. But Visitain is not available. So injection was given, and following that, focal laser was given at the point along with the micropulse grid. And after 1 month, the patient had a repeat OCT, which is seen in the right side. So I sent the patient back. I think it's some other patient's OCT mistaken, wrongly entered in this patient. But it was the same patient. It will completely gone within 1 month. And next 3 months, nothing happened. And after nearly 1 year, he started getting a PED back. So this is the usual picture of polypoidal choroidal vasculopathy. Even if you do PDT or any treatment, they are likely to come back with worsening of due to branching vascular network. So take home message, it may be an option in some of these cases where you are fed up of injections. Case number 6, this is another one, PCV. Actually, patient has taken injection multiple times elsewhere. I would have left it untreated because the vision is not very good. But I thought I will try this micropulse. I gave one more injection and treated that area with micropulse. That focal polyp is bang at the fovea. I did not have PDT at that time. And so after treatment, laser was given. And 1 month later, vision little less, but gradually the whole thing started reducing. And over the next 1 year, the macula became flat and the X-rays disappeared. So this is the pre and post of that same case. So after one treatment of micropulse laser, it has completely gone. This is another polyp with thumb-shaped PED and double layer sign, classic with a network. And patient had taken multiple injections. It is recurring. So this case also I gave a grid of micropulse subthreshold laser along with injection, and it became dry for 6 months. Again, it started coming back. So some cases it may work for the intermediate time. This is another case where there was a branch retinal vein occlusion. Here also you can see that why it is recurring after injections, because it's in ischemic retina. You are not treating the cause, unfortunately. So this case, I gave a grid of micropulse. We used to give focal laser to the ischemic area in the olden times. So grid of micropulse along with injection. Actually, that edema became less, but the hard X-ray clumped at the fovea, because you can see that that typical OCT biomarkers are there. So these are some cases where I give for DME, the focal laser to the microaneurysms along with a micropulse grid in that whole area. It may work wonders. Left eye, there's a pre and post treatment. This is another pre and post treatment. So this I have been doing for past around 8-9 years. So in other words, this is not a magic. This is useful in some desperate conditions where you are fed up with the injections or there is no other way. Talk to the patient. Since it is subthreshold, the endpoint is not visible, just like transpupillary thermotherapy, and retreatments may be needed. That is another important point, especially in CSCR. We give one micropulse and then call after 1 month, 2 months, nothing will happen. You may have to repeat the laser once again, and probably it will work over the next few months. So these are some of the negative points. It is not the first line treatment, definitely. And I am showing only good cases. For every good case, there is 20 bad cases also, which it has not worked. So if you ask me, is it worth investing in micropulse? No. Thank you.